Okay. So good morning, the people on this side of the oceans and the ones who are enjoying. We should show you guys the fall colors. They're beautiful. Lakini baridi tunajua inakuja, but welcome. And then good evening, the people back home. And the ones who are gonna watch us on Facebook, good morning, good evening, good afternoon. Welcome to this conversation on autism. I do not know the correct term. They will teach us what the correct term is, but we'll go with autism for now. And Saya, as usual, tufungulie kituo na kizungu ya Mrs. Mbogo. Karibu.
Okay, sorry. I hope you can hear me. The Mrs. Mbogo line got me. The world has very many fires burning at this time. There's, of course, the political and the wars that are ongoing. And then there's basically a battle about ideas. And one of them is a branch of the whole pro-life, pro-choice thing. And a cousin or something, a cousin to that is the whole like end of life discussion, medical assisted suicide and all of that. And one of the arguments that is common in both has something to do with quality of life. One of the indices, so people who argue for medical assisted suicide or who argue for abortion, one of the things they use is, hey, if the quality of their life is not going to be assured, they're pro ending life, whether it's for the unborn fetus or for the living human. And it's that word, quality of life. It's a very, what is it called? It's a very subjective measure, because in the past, individuals have used indices like income level, race, neighborhood as a measure of quality of life. And so one of the things used in that whole quality of life is today's topic, when now medically we can be able to determine, while the baby is still unborn, whether they're going to be autistic or have an inclination to autism. The proponents begin saying like, okay, because this gene is discovered or autism has been discovered, we need to end this life, or we need to encourage the mother to end this life. Or if somebody has been born and is found to be autistic, there are aggressive suggestions to end the life on the bracket of this fairly loosely defined thing called quality of life. On the other hand, the opponents of such ideas, outside of the understanding of, say, religious ideas around the dignity of all human life, argue that we try to play God when we pick an index like somebody's going to be on the autistic spectrum, and therefore we already prejudge when they're in the womb, or we prejudge when they've been born, or even we prejudge when they become old and some of the autistic spectrum things begin emerging, that they're, again, that term, the quality of life, is not going to be worth living. And in their argument is a good litany of individuals who are either rumored or proven, or who've come out as having been individuals within the autistic spectrum. Of course, probably the most famous is two scientists. One is Isaac Newton, and the other one is Albert Einstein, who were on that spectrum. But then we do have people like Dan Aykroyd, the guy who wrote Ghostbusters. We have actors like Anthony Hopkins. It's even argued that Charles Darwin, the father of the whole naturalism and evolution thought, was within the autistic spectrum. And even right now, there are people who argue that maybe two of the most current innovators we have in our time, Bill Gates and Elon Musk, are within the same spectrum. And so was artist and painter Michelangelo, who was inspired by the Renaissance to put some of the most beautiful works of painting, but also put together some of the most interesting prototypes of aviation and the rest. And so whichever place of this argument you fall, it's quite formidable to begin imagining what, some of these impressive people you mentioned, and they've spanned all, they've spanned all disciplines, from the arts to the sciences to society to acting to innovation, various disciplines. And so it's one point to consider. As a child born in the 80s, I was actually born just a few years before the HIV virus was isolated and HIV arrived in my country, Kenya. Back then, my father worked in a lab, so my exposure to matters HIV, education, knowledge, and everything was perhaps in advance of people, my peers, and has remained that way, maybe because I also stayed within the medical field and at some point later on did research in the field of HIV/AIDS. Back in the 80s and the 90s, and in Africa, a good part of the early 2000s, an HIV diagnosis was synonymous to death. Like when you're told you're HIV positive, we are basically beginning to ask you to put your life in order. Back then, the treatments were not great, and when they were available, they were extremely expensive. And so HIV equals death. But over the years, we've been able to have ART therapy, we've been able to get better diagnosis, and now we've moved from a whole cocktail of drugs to single pill for HIV. And so HIV has, in many regards, now come to the level of diabetes or heart disease, which we can manage and live with. Why am I saying the HIV story? I'm just thinking the same thing about autism. In traditional Africa, when a child was born and were autistic, that was a death sentence, because it was believed that this is either a sign of a curse or something is wrong, or you've married a very close relative. It was nothing positive about it. And even in modern Africa, our lack of knowledge and at many times lack of empathy meant it was going to be a death sentence, either in the social life of the person or the persons around this person, or we've seen people within the autistic spectrum being chained, others being banished, and even in more African countries, there was killing, there was infanticide for children who were suspected to be in the autistic spectrum. Why? Because just like when HIV was to us in our 80s and 90s and the early 2000s, a death sentence, autism has also been seen to be a quote-unquote death sentence to many individuals, and they have resorted to either take matters in their own hand, or those who try to sneak and run away from it end up living a life that is hidden and less than optimal. But again, I go back to my list. What if the child we are putting to death, or the infant we are smothering and killing, or the one we have chained away is actually the next Isaac Newton, or is probably going to, or could be the next Elon Musk, or the next Bill Gates, or the next inventor or actor? What if we were able to do to autism what we have been able to do with HIV? Hit it with information and cure and management, so that A, we destigmatize it, and B, we move it from being a death sentence and instead begin seeing what is leverageable within it, so that we shall be able to tap into the genius that is very presently there. So whether you're looking at this discussion today from moral arguments, or you're looking at it from purely practical elements, it's time we need to have an authentic and very candid discussion around autism. Back to you in studio.
Thank you very much. And so for us to demystify, we need to understand what autism is. So I need to throw it to the specialist. So we'll start with Lambert because he's been in the game a bit longer than you, Nema, Paule. So Lambert, tell us, okay, first, what's the correct name? What's the definition of autism? You need to unmute.
Okay, thank you very much for having me in this very timely program. And I'll go straight to the question. What is autism? Autism is what is called a neurodevelopmental condition. So this is a condition that presents itself in childhood. And you'd find that as a child interacts with the environment, as a parent, as a guardian, you'll start noticing certain patterns of challenges with socializing, challenges with communication. You'll find a child is unable to express himself when there's milestones where the child is expected to say certain words. They might have difficulties expressing themselves. They might have difficulties with touch. They might have a nature of just having a need for sameness, a repetitive pattern. They might like objects that are moving round and round, lights, etc., etc. However, back to autism, because I've just described autism per se, it's actually recently it was put under spectrum because statisticians, scientists looked at who have spent a lot of time studying about autism. They said, okay, let's just put it in a spectrum of a number of conditions which are very similar in terms of symptoms. And then now we can say a clinician or a professional can actually use his clinical observation and judgment to determine whether this person on the spectrum might fit the criteria of, let's say, for example, what you call Asperger's syndrome. There is also some kind of features or maybe challenges, the intellectual functioning, which also might be put in there, extend, et cetera, et cetera. And then now the autism condition per se. So it's on a next spectrum, and that is now how it is when it comes to autism. So it's called autism spectrum disorder. It's a neurodevelopmental condition or a set of neurodevelopmental conditions.
Thank you. Nema, do you want to add to the definition and to the spectrum? I know most of us know about Asperger's and just autism itself, and the ones Lambert has mentioned. If you want to Kenyanize the definition even better.
Okay, thank you so much. Thank you so much, Posa, for having me, and nice to meet you all. So, yeah, I think what Lambert has said is quite precise, that autism is a neuro means it's in the brain. Developmental means the way the brain develops is actually different from a typical, what you consider to be a typical brain. A typical brain is, you see, when you look at the Bell's curve, the normal distribution curve, a typical brain is where you have the highest, what do I call it? The highest, like a mountain. That's where typical is. And then anybody else who lies outside is atypical. Yeah. So when autism, the way the brain of an autistic child develops, it's not in the typical way. That means this child will be born like any other child, but as the child progresses, as the child is expected to achieve the milestones, then the milestones come in differently. Yeah, that's what it means by neurodevelopmental. And I know it's called autism spectrum disorder. Personally, just to reflect with what Saya had said, I think they use the term disorder because of lack of a better word. Because when you look at how diverse the autistic is, I think it's just a different way of expression of humanity. And I know, and I think that's where it comes to what do we do? Is it pro-life? Is it pro-choice? And of course, that's going to be a discussion. Maybe we are going to have it here. But just to come to your question, what autism is, it's a neurodevelopmental disorder. And usually autistic kids have two major things, which I think Dr. Lambert said: the social, the speech and communication, and then the restricted repetitive behaviors. Yeah, so those two are the hallmarks of autism. And then on top of that, what research has shown, 70 to 90% of kids will also have other conditions, either intellectual disability, learning disorders, other things like epilepsy, like so many other things can come together with autism. But when you just talk about autism, it's those two major parts. Yeah, it's a spectrum, which means we have the mildest, which is level 1. I don't want to use the word mildest, but I think I'll just use it for the sake of understanding. So we have level 1, which the levels majorly speak of how much support they need. And it's usually not a fixed thing. So usually it's a very fluidy. So a child may start from level 3, and with interventions, they may move to level 2 to level 1. And so usually, the levels come in during diagnosis and during assessment and during education, just to know where exactly to place the child and how much support they're going to need to make their life better. Yeah.
And Lambert, you said this diagnosis is made in childhood, but there are some people we called quirky who are now, when we think about it, they're under the spectrum and they're in adulthood. Can this diagnosis be made later in life, or it has to be strictly within in childhood? And if in childhood, am I able to diagnose my 3-month-old, or is there like an age? What's a beginning cutoff point? Kizungu inaisha, the beginning starting point. Kizungu baya, but yeah, you get my point. You need to unmute. Okay, can Nema take a stab as you find your microphone? Okay, Nema take a stab. Lambo ajipange kwanza.
Okay, so yeah, so it's true. Actually, what we are seeing is, I think in the last 10, 15 years, the prevalence of autism has increased by more than, I think they say it's 400%. Like, so many people have been diagnosed. And yeah, as you said, it's from infants all the way to 30, 40, 50. I mean, people who have families have actually come to a realization, oh, now I understand why I have been struggling with this. They actually are able to see themselves on the spectrum. Like, these are people who went through life, did not know why they're having challenges with all these things. But finally, with now, I think with the awareness and more, so we have different ways of diagnosing different age groups. So I think with those developments, now we see more and more people actually coming to realization that I'm actually on the spectrum and these are my challenges and this is how I've been using to cope. So we usually even use those people to help us understand how can we advise the younger children who we are actually now diagnosing and are going to live this life. So to answer your question, the earliest you can diagnose autism is 6 months. That's the earliest. And usually you can only suspect, and so they're usually the telltale signs. At 6 months, you'd expect that eye contact. At 6 months, you'd expect social smile. Like, this child should be interested in the environment. At 6 months, you'd expect cooing and bubbling sounds. Yeah. So if you are missing that at 6 months, you see those as a social communication. You may not really be able to see the restricted repetitive behaviors yet at 6 months, but the social communication at 6 months, you should be able to pick that. So if you're missing that, then it's nice to just seek medical assistance, and you're going to be advised. But the best time, like a definitive diagnosis of autism, usually is from at 18 months, 1 year and 6 months. That's when, because this child is expected to be talking, to be communicating, to be playing with others, So you can only get that definitive diagnosis. The earliest is at 18 months. Yeah, but from that, you can have it anytime along the way of life. Like even at 20, 30, 40, 50, you can still have the diagnosis. If you feel you're not just understanding why you're struggling with things that are otherwise very simple to other people, it's nice to just go. Yeah.
Okay, Lambert, same question. You can let her have Jibu Sasa. Okay, let's see.
Okay, thank you. Thank you. I'm back now. Really, when it comes to this condition, it's a very tricky thing, because like you find presently more and more adults who are seeking help and saying, I think I'm on the spectrum. And really the only way to for sure determine whether they are on the spectrum is to do an assessment. And sometimes they're missing gaps, because this person is reporting by themselves about his or her symptoms. And at that stage, what is important, and I think this is something we'll discuss later, is to focus on how is it that this person has been able to cope all these years. There must be certain strengths about the condition, despite him having had this challenge. They are probably doing very well at the very moment, and it's out of curiosity and perhaps wanting to perhaps do better in whatever they are doing, maybe in relationships, in their careers, and so forth and so on, that would make them seek an assessment. But back to childhood, really, like Neema has clearly put it, the age, for the longest, when we look at a manual called the Diagnostic Statistical Manual 4, it used to say that you wait until a child is 3 years old, then you can actually give an official diagnosis. And before, out of a lack of knowledge, then, and that is what you are working with, would actually meet people and we would tell them, no, let's give it time, because of course we have to follow the manual that we are using. So not knowing that actually there's a lot that can be done with early diagnosis. And perhaps that is what is happening now. Maybe more and more people are aware. We have actually done a lot of campaigns, matters stigma, managing this stigma discrimination. And I think now people are coming in big numbers. But I think also when we look at the causes of autism spectrum, I mean, there are many other variables which I think scientists are still trying to find out that could actually perhaps explain why the numbers have gone up. At this point, we might not really know why the numbers, we might not entirely know, but partly what we can say is maybe because of more knowledge, people are now more aware and know that the sooner you actually diagnose this condition, the higher likelihood that you can actually help this child to be able to lead a meaningful life, depending also, like you're saying, on the severity. Thank you.
And just what has been the influence, the impact of TikTok and Twitter on the increase of diagnosis? Because I know there are so many psychologists, psychotherapists, people on the spectrum who are talking and helping each other on these two forums, especially, not even Facebook, TikTok and Twitter. And this is millennials and below who are doing most of the work. What's your view on that? We can start with Neema.
Okay, so I love social media. I mean, if there is one way that you can leverage on anything, of course, both positive or negative, I mean, it depends really what you're promoting. But I think there's so much power on social media. Yeah, TikTok, Twitter, Facebook, Instagram. You just need to make enough noise, as long as the noise is correct, is precise, because it's also a platform that can be used for, so much, what is this called? Fake news as well. So as long as the information is correct, the information is actually true, it's you sharing your journey. By sharing, you are actually allowing other people to also share. By sharing, you are allowing other people to relate to you. and see themselves through your lens. And if, assuming now we're talking about autism, if I say I've been having so many challenges, like I can't stand with people, I've always been particular on how I arrange my things. I cannot stand with people who keep on changing. Like if we plan to meet at point A at this time, and then all of a sudden you just change, I have to really, really find myself. I have to work up for me to be able to adjust. And then I say, oh, I'm actually like that. Then another person said, oh, I'm actually like that. And you say, okay, actually, I went to find out and I found that I'm on the spectrum. And when you share such a story, it simply means I could also actually just go, maybe I'm not, but also maybe I could be on the spectrum. So social media is such a beautiful platform for us to be able to share good, to leverage, to spread the good news, not only on autism, of course, but in every aspect. And I think that's what Lambert also said. We can use the people who have been living with this condition, by themselves, to see how best have they been able to use their strengths to rise up against everything. Because for us who have children on this, we really have to look at, you see, I'm a mother of a child on the spectrum. I'm not on the spectrum. So there are things that my son is going through, I am clueless about. But when I see another teenage boy, I see another teenage girl, an adult, sharing their story, it's very easy for me to relate and be able to see how best can I help my child, how best can I help the child the kids that I always serve to be able to live in the best way possible. Yeah.
Lambert, do you want to add anything?
Yes, wonderful question. Social media is fantastic. It has its pros and it has its cons. And I think Nema has just put it very well in terms of the advantages. Maybe I might want to just add a little bit on the disadvantages of social media or such forums, because when you think about it, I think social media has really helped in fighting stigma, especially with Gen Zs and the younger generations putting a lot of content out there has really, really helped. However, we also have to be very cautious because there are two ways of interacting with social media. There's passive and active use. And many a times when there's passive use of these platforms, then it can have an impact on the people who are watching. For instance, let's say you are someone who perhaps is struggling with a mental health condition, or if you're a person who is young and perhaps you suspect that you could be having a certain condition based on the symptoms. Or even more interesting is that when you look at some of the manuals we use, most of these conditions share very similar symptoms. So there's need for us to also be very cautious, and there's need for us to start appreciating, sadly, the gap that comes with a lot of psychoeducation, a lot of managing stigma, and then now you find that there is lack of enough mental health professionals or pediatricians, for this matter, who can do the screening and assessment. Because again, going for a screening and assessment can also be quite costly. And you find many people are unable to afford this. Then what happens to these individuals when they watch social media and they are unable to do much about it? One, what happens to when there's too much information and you get overwhelmed, and then it becomes counterproductive? So there are many ways of looking at it, but bottom line, there are positives about social media, but also we need to also have conversations about this because it is out there. And I think the American government, through the Surgeon General, he has actually been very big on this matter, which I believe would be a topic for another day.
Okay, thank you. So Nema, you're going to put both your pediatrician hat and your a parent to an autistic child hat. So, and let me put my MD hat just for 2 seconds and please offload it. When we tell, especially in the Kenyan setup, we only do child evaluations from 0 to 9 months. Once they are done with their measles, they are out of the game. And a proper diagnosis needs to be made at 18 months, and especially for the boy child who only gets to see the doctor later if they get pneumonia or they go for circumcision. The girl child will come back at least for menstrual issues and labor and delivery, but we lose the boy child in between there. So, and when I'm thinking about the road to health curve, you all remember your yellow blue card, the one which has all the curves. All Kenyans here know that. That's the only thing that a parent has to go with. How are they able to pick up that my child, there's something off? And if you're able to share a bit of your story, how were you able to pick that your child was on the spectrum? It will be, if you're able to, please let us know.
It's okay. So speaking as a doctor first, it's a huge challenge. We have a lot of kids that we lose along the way. And some come in, as Lambert said, I don't know, where is Lambert speaking from, if you don't mind?
Oh, from Nairobi.
From Nairobi as well, okay. So as Lambert says, so kids will come in, not even at 3, kids will come in at 4, 5, 6. And that's when the mother will say, so this is the common, at least from my profession, this has been the commonest story, that my child has had a delayed speech. Usually speech is usually the first thing. So my child has had delayed speech, and I consulted my friends, and I Googled, and I consulted my aunties, and I was told to just take the child to school and the child would be able to speak, because there was so-and-so who had delayed speech and they took their child to school and eventually they were able to speak. So this parent has taken their child to school, and this school have not been able to handle the child. So it's either the child has been abused physically, because they're trying to literally pin this child down, because this child cannot sit still in class, this child cannot concentrate, this child is the one who keeps on distracting the class. So this child has been punished every day, in and out. And now this child has lost interest in school. And so the parents have had to, switch to the second school, switch to the third school. And then that's when it hits the parent, okay, maybe we need to actually get our child to be seen by a doctor, or maybe even a teacher advice, maybe you need to take your child to be seen by a doctor. So that's when they come to the office. The other ones are the ones like you see, like, for example, so yes, it's true, we have 9 months, and then we usually have a repeat at 15 months, a repeat of measles. We repeat of measles at 15 months for all children who are taking the So when a child comes in at 15 months, so the parents who are very keen will tell you, by the way, my child has not spoken yet. Yeah, because that's usually one of the commonest presenting symptoms, that my child has not spoken yet. So you assess the child, and then you tell, okay, maybe your child is on the spectrum. But you see, that I don't know how it is in the US, but it's not a very easy diagnosis, to be sincere. It's not a very easy diagnosis. And so when you tell the parents that, they are like, you are seeing your own thing, and they disappear. Like, they do not want to see you. They do not want to come back to you. They'd rather go somewhere else. I think maybe they're going to look for a second or third or fourth opinion. And then maybe 2 years or 3 years down the line, they come back. And you're like, they actually come back. Now it's very evident that this child is actually on the spectrum. Yeah. So it's true, with the health system challenges that we have in Kenya, we have a lot of children who are lost under the cracks. And yeah, it's work in progress. We are really doing a lot on social media to just sensitize the people, but the stigma is there. There's a lot of denial still that comes with that diagnosis. And yeah, it's a journey, it's a process, it's not a one-person fight. But I think when we do it together with like conversations like this, we just raise up awareness of letting the parents know, if your child is on the spectrum, it's not a death sentence. It's not like, okay, this is it for my child. No, it's just a matter of you refocusing, shifting your mind, shifting the way you are looking at your child, see what they carry and really utilize on that. My personal story, so I got my first child when I was already a pediatrician. So I could actually see, okay, but by 1 year, my child was not speaking. 1 year, 2-3 months, he started speaking, but it was gibberish, like he just speak these words that really did not mean anything. 1 year, 6 months, 18 months, I was like, okay, it's tough, but my child could actually be on the spectrum. And yes, I was a pediatrician, but I did not go for assessment. I assessed my child at home, made the diagnosis. I had to come to terms with it before I garnered the courage to actually go to seek for that official diagnosis. So at 18 months, when I knew that actually my child was on the spectrum, I started doing my own quote unquote speech therapy of just trying to talk to the child, you know, like the way you do the way you communicate differently now, because now you're more intentional how to communicate differently, the different things that they can do to reduce their you know, repetitive behaviors, addressing their sensory needs. But I think I was able to do all that because I had that knowledge, I had that information. Then I went to seek the final diagnosis when I was about when my son was about to join school. That was at around 3.5 years. That's when I went for that official diagnosis, because then I needed some educational assessment, because I needed someone to be able to do that for me. Getting that done in Kenya is an uphill task. Like I'm still to get feedback from the institute. And this, my son is 10 years now. But trust me, after I started meeting those documents, I don't know how people do it. It's crazy. It's crazy. So the only other alternative is to go through a private consultant, which is expensive. It's very, very expensive. Get those educational needs assessed. And then now you start the journey of looking for school. I think for me, so in Kenya, there's a term we use, character development. I don't know if people understand what that means. It simply means your character is chiseled, you are humbled to the core. So for me, the journey of autism, I think getting a proper school education for my child has been the most devastating thing for me. Like that journey, anytime I speak about that journey, I get it. It's been crazy. My son is 9. We are in the 5th school as we speak. And yeah, so there were years we did 2 schools in a year, because you're just not able to get your son and the teachers aligned. It's crazy. Yeah, it's crazy. So I think in a nutshell, I think maybe I'll just end up there so that, yeah, we can proceed with the discussion. Yeah.
And thank you for sharing your story. Thank you. My heart goes out to you. And now I have to shout to the teacher, because we have mentioned teacher very many times. So these children fall, even here, right? Because Trish is in the States, fall through the cracks. So how do you catch it on your end?
Okay. Good morning, good evening, good afternoon, everybody. Posa, thank you for having us on this forum and giving us the opportunity to share our insights on a subject that is like prevalent, throughout the world. It's not just Kenya, it's not just the US. It's something that affects all of us globally. So my lens is from a different angle. I'm in education. So I'm an assistant principal in the New York City schools, public school system. And I head a school that's predominantly students with autism on the spectrum. Being on the spectrum basically means that you exhibit autism differently. So when you're on the spectrum, it just means that it's shown differently in different people. A lot of our students have comorbidities, which means that they have autism and then other issues on top of that. So they may have autism and coupled in their ADHD. Many of them have speech and communication disorders. So it's a lot. We get students who have, a lot of issues. And within the US, the education system demands that you put the child in the least restrictive environment. What that means is that, yes, we do have schools and special programs for students with, disabilities. However, the push is that you integrate them into the general education population as best as you can with the supports that they need in order to thrive in the general education population. However, as mentioned earlier, it's a spectrum. So there's some on this side of the spectrum and others on this side of the spectrum. So you have those with Asperger's. Those are the more functioning individuals. They tend to thrive academically. And then you have the others on the other side of the spectrum. Now, these are your nonverbal, those whose grade level does not necessarily match up with their intellectual level. So you can have somebody who's 13 years old and their thought process is as low as a 6-month-old child. So there's that huge gap, and trying to bridge it and give the individual the access to, general education, and also the access to having a quality of life when they go post-secondary. So how do we function? So first of all, in the US, they actively ask you to make sure that you seek medical consults prior to the child turning 2, because there's this thing called early intervention. And what they say is that early intervention is best suited before the child turns 2. So you rigorously, one thing we have to understand though is that autism is not curable. It's not curable. We just try to help the child manage and be able to access the world from their viewpoint, from their lens, but in an acceptable way, right? So that's one thing that is difficult to express to parents, is that it's not curable. So you have that challenge. And then the stigma related to autism, again, parents were scared to go and seek out the information, because then to be told that your child has autism, they don't want to hear it. So for us, it's harder when you're telling somebody your child is not getting it in class, your child needs support. Then again, they don't want somebody tailing behind their child, because sometimes they have the speech therapist coming in, the occupational therapist coming in. Some of them have a one-to-one paraprofessional for behavioral challenges. Others have a one-to-one paraprofessional for health challenges. So they feel that their child will be stigmatized because somebody's following them all over the place. However, the reason for that is for them to get as many supports as they possibly can while younger, and those supports fade off as they get older and they become more independent. So once a child comes into the school, and another thing is, in the US, you have to do a physical for your child every year. Failure to do so, your child cannot go to school. Give me 1 second, please. JR? Somebody's desperate. Posa, can you continue? I'll be back.
Okay.
Thank you.
Mute on your end so that we don't hear you whooping the child. Okay, let me see. So Lambert, then you can touch on the comorbidities that that Trish has brought up. We hadn't, because my mind is all over. Sometimes I think, just touch on the comorbidities,
Okay, because really, like we had mentioned earlier, as much as there's this bit of a spectrum, you'll find that most conditions, specifically now when you talk about neuro or cognitive or developmental conditions, find that there will always be another condition that will be there, be present, and it's important that you pick it, assess it, and find a way, an intervention. And she's talked about, for sure, ADHD. You'll find many children who are on the spectrum are also extremely hyper. They have lots of energy. They have problems concentrating. They tend to be impulsive, so you'll find that they'll be prone to accidents. And that, of course, means that they have to be under very close supervision. So if we only manage autism, for example, without managing the ADHD, then it can be complex. Then, of course, she's mentioned also, and I'll repeat this, matters to do with, because again, you're talking about issues to do with communication, socializing, and what you'd call intellectual challenges or disability. So you'll find that if you're on the spectrum, maybe on the higher end, then you might find then a child might have much more challenges with really taking care of themselves, being able to sit still or learn in class. So you find that there's a challenge in retaining information and being able to really be independent. So like she had mentioned earlier, you find that autism is a lifelong condition. So when it's severe in childhood, then it can be a little bit complex. And we're saying really, it is a very challenging condition, especially when it's on that end of the spectrum, becomes extremely important. Another condition I think Dr. Neema talked about, physical health issues might also present, matters to do with epilepsy, for example, might actually be present. Maybe even diabetes and all that, some children might have that, so it becomes extremely challenging. Of course, we've talked about the other end of the spectrum, Asperger's. You can imagine someone who is extremely regimented, very organized, very sensitive to touch, so might have problems with even hugging people, getting close to people, might have challenges with the way they express themselves. And that can make this person to be prone to bullying, for example, prone to problems with developing relationships with others. And certainly then issues to do with anxiety and depression can start presenting themselves, and perhaps not immediately, but much, much later in life. So those are some of examples of comorbidities rather that will present in children or even adults on this spectrum. Maybe Dr. Neema, if there's something I've left out, you can feel free to chime in.
Trish, we're just adding on the comorbidities you mentioned, then we'll come back to you. Okay, Neema, go ahead.
Okay. So I think you've been very comprehensive. So the behavioral disorders are usually one of the commonest, and then of course the mental health. Although there are different school of thoughts when it comes to mental health. They were like, what is it the stress that comes with autism that predisposes them to mental health, or is it that autism itself, like removing the environmental aspect of it itself predisposes them to autism? So mental health is a huge depression. They're more likely, it's actually 70% more likely to be depressed. They're more likely to be lonely because of now the environment, how we look at them, how we see them, how we judge them. And as much as we're talking about autism, the autists themselves, the families that take care of children on the spectrum are also at a almost 10 times more prone to mental health issues because of the stress that comes with taking care of children on the spectrum. Actually, what research has also shown is that parents of children on the spectrum are more stressed than a parent taking care of any other disability, any other. Yeah, so the mental health aspect is huge when it comes to, parents and families, and also the children who are actually autists on the spectrum. Then we have learning disorder, which is something I'm also personally going through. Different learning disorders, the school systems that we have. It's a lot. It's a lot. So to answer your question, so we have the behavior, then there's the learning, then there's the mental health issues, and everything else, the organic things like diabetes, hypertension, and then there are those ones who, I don't know if I'm supposed to say this here, but there are those ones who, there's also the issue of cancer, especially for those who attempted the stem cell aspect and it never, because you're not assured if you do stem cell, you're actually going to, go through. So you do stem cell, you continue with autism, and then the risk of cancer also increases. Now, we're not sure if it's what caused the other, but there's also that aspect. Yeah.
Okay, so Trish, if you remember where you are on your train of thought, go on.
Okay, so I think I was mentioning the fact that in the US it's a little bit different. Parents here have more options because first and foremost, the child cannot come to school unless they've had a physical yearly, an annual physical. And if a parent does not do the annual physical, then it's reported to the state as parental negligence, which is child abuse. So you're almost forced to do it. You know, if you don't have the funds to do it, there's Medicaid and Medicare that takes care of that. So parents do have the option. There's pediatricians available. The state will pay, the government will pay. And so once they come to us and they've been diagnosed, we do what is called a psychological evaluation. So that is done by the school-based support team, which is a team of school psychologists who are experts on that in that field. And they're the ones now who will either diagnose, if they not diagnose, but verify whether it's autism, whether it's ADHD, whether it's OCD, whatever it is. And then from that point on, now we're able to put the child in the best placement, or rather the proper placement based on the disability. So then how do we teach? We're big on ABA therapy, especially in the elementary stage. ABA is huge. You know, we work hard with ABA. And then when they get into middle school and high school, it's predominantly the teach methodology, which is more like a workshop model where you teach a child how to do something first, then, and then finish, first, then, and finish. Whereas ABA is more repetitive until the child gets the hang of it, and then you move on to something else. With ABA comes a reward system. So you do it, once you get it, you get a reward. You do it, once you get it, you get a reward. Then you try to fade that off because you don't want the child to think that every time that a demand is placed on them, a reward is coming after, because some things have to be innate. You have to just do it. You know, that's how society is. You can't go to a job and expect an employer to keep giving you a reward every time you do something that's expected of you. So the predominant thing that we do in the schools is make sure that we fade all these supports. Because at the end of the day, you want to make sure that the individual is as independent as possible and can manage in the outside society where we're not there to shelter them and to, you know, buffer everything else. What's another thing that we find in the education system? So as mentioned, the comorbidities, for the most part, you know, we're trained. So educators who teach students with severe disabilities are trained. And that's one thing. With the US, everything is, you have to be trained in order for you to be in a particular section. You know, in the medicine field, you have to go through all that rigorous stuff before you can actually sit down and practice. There's no quacks out there, quote unquote. So the same applies to us. A general education teacher cannot sit and teach a special education student because they don't have the license or the qualifications to do so. So for us who are special educators, during our time in college, you know, we're taught that psychology is huge because a lot of the neurodiverse issues and then anything to do with that realm, you know, we have to know, because you could be having a child sit down with students with autism when really their disability is totally different. They're probably just dyslexic. And due to that disability, they tend to mute. So, you know, they just don't speak because they don't want to get embarrassed. So, you know, we're trained to be able to pinpoint all that. A lot of our students have speech services. They have occupational therapy services. They have counseling and physical therapy. So as mentioned, a lot of them have health issues. Some may be due to the fact that there's certain things that they just won't eat. And it's maybe textural because they have, what is it called? When they don't, the tactile thing where some certain textures just don't sit well with them. So they won't eat specific things. A lot of people say go and get them food that doesn't have, everything is going away from me now. But if you're within that realm, you understand what I'm trying to say. So their diets tend to be more limited because you're trying to avoid certain things because they trigger this or they trigger that. So the child's diet is very limited. So you find that they have a lot of other, you know, health issues that come along with that. When it comes to the speech, some of them are nonverbal. So in the US, what we do, we provide them with a communication device. And what that is now is like an iPad or an iPhone that helps them communicate. And so the speech therapists work with them to be able to learn how to use that device. There's a lot of programs you can use, Proloquo, LAMP. All those will speak what the child is requiring. So there's icons and the child just presses the icon and it speaks what they need or what they require. But again, those devices are expensive, you know, a whole iPad. And then getting the program again is another expense. However, the Department of Education in New York City provides that. So the child has that access until 18. And that's why I keep trying to emphasize the fact that we try to fade off these supports, because once they leave us, how independent are they? How much capable are they to function outside of, the umbrella of supports that we've provided? So for those who are on the other side of the spectrum, Asperger's and what have you, we try to integrate them into the general education population. Now, when we do that, we send them in with a special education teacher. So you have classes like ICT or SETS, where there's a special education teacher and a general education teacher. So they teach together, but the special education teacher is there to actually focus on our special education students and provide them with the additional supports that they need. Now, any child who has a severe disability or a disability of any sort, under the IDEA law, which is a law in the United States, they're provided with an IEP, which is an individualized education program. Now, that is a legal document. Whatever is on that IEP has to be manifested in the classroom. So if it says that they get their test read for them, you will read that test for them. If it says that they get double time on an exam, they will get double time on an exam. And that's on national exam, that's on any exam they have to take. They will get those accommodations and modifications. If it says that the child has a one-to-one paraprofessional for support in the classroom, that one-to-one paraprofessional should be there for the duration of time. If it says full day, it's full day. Don't think you'll walk away for a minute. It's full day. If I walk away, somebody should come and replace. That's how stringent they are on the supports that these students are given. Then we have, they do take the exams, they take the national exams. Like I mentioned, we give them the accommodations on the exam so that they're able to thrive as best as they possibly can. When we switch over to the other side of the spectrum, the one-to-one paraprofessional might be there for behavior. So you do have students who get overstimulated and then they just have a breakdown. So they have meltdowns. It can get very, very intense, extremely intense, to the point where they can hurt themselves. They could hurt the staff members. They could hurt other students. So in a situation like that, we have something that's called a behavior plan that's put in place, where you see the antecedents. So you know what triggers the child, and you're trying as much as possible to create an environment where those triggers don't come in. Or we introduce them minimally so that the child can start to learn how to manage that. If, say, for instance, they know they don't like math, what can we do? Maybe 5 minutes before, keep reminding them, okay, we're going to math now, we're going to math now, we're going to math now, rather than just bring them to math and then it's a whole full-blown meltdown. For those students, they do have a one-to-one paraprofessional. What that person does, they are there particularly for that one student to support with education and also behavior. So that one-to-one paraprofessional should be tracking behaviors. So how do we give a child a BIP, or the behavior intervention plan? The behavior has to be frequent and the intensity has to be like super intense. So there's levels to that. If it's a level 3, okay, that's something maybe we can just incorporate where all teachers are made aware. Maybe the student needs a 5-minute break every 5 minutes. So let them lay their head down. Do not put pressure on them. They could lay their head down, and then when they're ready, they can proceed and get back to the classroom. Then there are those who are at a level 1, where even putting their head down is going to disrupt the entire class. Now that student has a one-to-one paraprofessional as well as a BIP and an FBA. And FBA is our functional behavior plan. So teaching in special education is hefty. It's a lot, because we have all these things that we have to do. They are mandated by states, they are mandated by law. So we have to make sure we have them. Failure to provide, we get sued. And we have a lot of lawsuits that come through and the parent wins. Now what that does is that when they sue us and they win, we have to either provide the services or the parent gets private school, right? Private school, of course, will be better because smaller class sizes, services are on campus and all that good stuff. Another thing is that the students on the spectrum or students with disabilities, on their IEP, there's a ratio. So you cannot exceed what's on the ratio. So if the class size is 6 to 1 to 1, which is 6 students to 1 teacher and 1 paraprofessional, you cannot exceed that. If it says 12 to 1 to 1, there has to be 12 students in the class, a paraprofessional, and a teacher. So you cannot exceed the mandates that are on the child's IEP. As well as if they get speech, occupational therapy, and all that stuff, you have to make sure you provide those services within the ratios and the mandates on the IEP. How do we write IEPs? It's a collaborative effort. The school psychologist is present. The special education teacher is present. A general education teacher is present. a district representative who's either one of the coaches or the principal or the assistant principal is present. The parent has to be there. And if the student is capable of being in the meeting, they're there too. You don't exclude those parties in the meeting. So everybody is there. It's a collaborative effort. And also there's parent training and counseling on the IEP. So what that is that the school is mandated to provide training for the parent periodically. So we have like seminars where parents come in and the speech therapist is going to say, you know, what strategies they're using and how you can carry that on at home, because consistency is key. That's another thing. Our students come to school 12 months a year because we notice that any gap in instruction causes fallback. So we have to keep them coming to school because in America, you know, it's 10 months and then they're off the whole summer. So if a kid is out the whole summer, when they come back in September, it's total mayhem because now you've changed the routine first, you change the routine. Then number two, they're coming back and you're putting demands on them and they haven't been consistently doing what they're supposed to be doing. So that's another thing with them. There has to be constant repetition so that they do not forget. There's also this thing that they do that's called stimming. People think it's a bad thing, but that's self-regulation for them. In Kenya, you know, it would be, stop doing that, and smack, 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 smack. That's not helping. That's how they self-regulate. You know, we have our own little things where, you know, we do to self-regulate. Maybe sit down and listen to soft music. For them, it's probably the rocking. It's probably the flicking of the fingers. You know, that's how they self-regulate. So before we used to try and stop the stemming, but recent research has said, don't do that. Just give them a time frame to do it. Say, okay, you have 5 minutes, go stem and then come back and join the class. The other issue that we find is a lot of echolalia. That's where they just repeat what you say. They just repeat what you say. And those who come to us later, like let's say 6, 7 years old and they haven't been diagnosed, that's a quick telltale sign for us. So you ask a child, what's your name? And they repeat, what's your name? So you can say, my name is Patricia. Then maybe they'll pick up and say, my name is John. But it's not automatic. So the echolalia is one of the ways that we can tell with the older students that they're on the spectrum. The other thing is where they perseverate. They just focus on one thing. It's one thing. You cannot take them away from that thought process. So those are a few of the things that we notice from those kids who haven't yet been diagnosed, say in general education. So a general education teacher will say, you know, I keep asking the same a question and he keeps just repeating what I'm saying, or they cannot get away from a particular topic. That's when our special education teacher comes in, looks and says, okay, this child needs to be evaluated. And then that's when we call in the school psychologist and the school-based support team that now does a full, you know, psychological, psychoeducational assessment. And then that's when they'll say, okay, the child is on the spectrum, should be moved to special education. But then again, special education is not, it shouldn't be a prison. It's almost like a temporary place where you teach them how now to integrate back into the general education population, because you want them in the least restrictive environment as possible. So we're just there to provide the support, fade out the support, and then move them back into the general population. So I know I've said a lot, but yeah, that's pretty much where we come into the picture.
Walimu walipwe. Okay, I'm just tired. Just thinking about all. Oh my God. Okay, but just one question, Trish, before you look like chopped liver over there a bit. So what happens in post-secondary if they do they go on, especially not the ones on the Asperger's spectrum, the other on the lower end of the spectrum? What happens to them, or do they go to just? Okay,
so at my school in particular, what we do is between the ages, so I'm middle school and high school. We used to be elementary all the way to high school, then the school became too big. So they split us and we took middle and high, and then another principal took the elementary. So what we do in the middle school is pretty much academics. It's straight academics, but again, we have to modify that academics. It looks very, very different. Like I mentioned, you could have a student who is typically 17 years old, but the brain capacity of a 10-month-old. So it's very, very basic stuff. Can they write their name? Can they fill out a job application? Are they able to tell basic time? If they go to a job and they're told, hey, your shift is in 2 weeks, do they understand what 2 weeks is? So it's very, very rudimentary, but it takes time to impart that knowledge. So when they get into the high school, up until the age of 17, it's the same thing, kind of like, repeating and repeating and repeating, so that they have those basic skills. And a lot of teaching behavior and social interactions with people. You don't just come into somebody's space, giving personal space, because they struggle with that. Those are the things that they struggle with. Things like ADL skills, that's your own personal hygiene, taking care of yourself and stuff like that. Once they get to the age of 18, now they go out to work. We call it work site. So we have organizations that partner with us, and they allow for our students to come and work in their organization. So we have like Old Navy, we have Gap, we have restaurants, we have elder homes, we have the hospital. So students, based on their interests, are sent to those places to work. Now, what is that doing? We're giving them a resume. We're giving them a resume that when they age out from our program, they have a portfolio that they can go and say, I've worked at this place, I've worked at this place, and I've worked at this place. And the US is trying as much as possible to do, diversity and inclusion. So they will hire our children, our students, and they have a job coach who checks in with them from time to time. So yeah, they find placements, and this is for, the moderate. We're not talking about Asperger's. Within this other side of the spectrum, there's the moderate, and then there's just, the severe. So the moderate ones, that's the path that we're seeking. The more severe ones, they go to a program. It's like a group, it's almost like the setting that we have, but now for older people. Once they turn 21, they age out. So it's like a program where they're given an opportunity to have a quality of life. Again, the benefit of being in the Western world, the taxes that people pay go towards supporting, various things, social structures. So state pays for it, where they go to a program every day of the week, Monday through Friday. They have enrichment programs, they do little skills here and there. They're taken to the mall, they're taken out to eat. Some of them go and live in a group home. What that is that they all live together, and they have caregivers who come in. Some stay full-time, others take shifts and come in and go. Others continue to stay at home. And at the age of 18, we start to have that conversation with parents, because once the person turns 18, they become a legal adult. That's another thing. So once they're a legal adult, they can make decisions on their own. If, say, for instance, I take, if I had a child with a disability or on the spectrum, and I take them to the doctor, if they go to NAMA and NAMA says, do you want mom here? And they say no without any thought to it, I gotta go. I can't be in there. So we try to talk to parents and tell them you have to sign up for legal guardianship. That's the only way you can protect your loved one, because once they age out and they turn 18, if they decide I don't want to take this medication anymore, and you go and tell Dr. Nama, and Nama is like, take the medicine, the person tells you, I don't want to, for whatever reason, there's nothing you can do. But if you have legal guardianship, you're able to, speak to Nama, and say, listen, he's not taking his meds, what can we do? That may be different in Kenya, because I know information is just divulged to family members any which kind of way, because I can call from here and say, hey, how's my dad doing? And they'll be like, yeah, so Mzee is doing this, that, the other. It's divulged, no questions asked. But here, that's a violation of the person's privacy. So once they turn 18, if you don't have guardianship, there's very little to nothing you can do when they make decisions. So those are the little things that we talk to parents about when they age out. You need to get legal guardianship. You start to look early for placements that are suitable for your loved one. You have to decide, am I going to be the caregiver when they leave, or am I going to send them to, a group home or to a day program where they go and they come home? The other thing you also have to think about, who's going to take care of this person once they're elderly and I'm not here anymore? Because people die. You know what I'm saying? I hate to be morbid, but these are the conversations we have to have. They're hard conversations, but you have to have them. Once you leave this earth, who's taking care of your loved one? Many people will say, oh, the brother, the sister. But have you spoken to the brother and sister and made sure that they're on track with that decision? They have their own lives to live. They didn't birth this person. So you have to really consider that, have a conversation at home as to who's going to take over if, God forbid, something should happen to you. So those are the conversations we have around post-secondary placements and post-secondary life for our individuals who have special needs. Sorry.
Haya, turudi nyumbani. Reality on the ground. Let's start with Lambert. So forget what Trisha said, Juyo near US, but what are we actually doing on the ground in terms of therapy, in terms of schooling, just the whole spiel, what Trisha has done, but the situation on the ground. And all teachers and all educational facilities need to listen to this video.
Okay, unfortunately, I'm not a teacher. So
no, in terms of
don't...
on the psychology, I mean, they come to you. Like when, yes. Okay, let's start. When they come to you, what happens? And then in terms of therapy, what do you offer? Yeah.
Okay, that I can answer. The reason why I was saying jokingly I'm not a teacher is because, really, I've just listened to her, and I'm really impressed and very hopeful that we can, in the near future, because we're in this space, continue having conversations and go beyond the conversations. Because I do believe that some of these programs can actually be replicated in this environment. And they work very well. Now, back to your question about what I do. Of course, we come across children, even adults who are on the spectrum. And the reality about our system is that they have tried, because there's a time I went to a school, I won't mention the school, and I think the example, for example, matters to do with reading using Braille, children who are blind, children who have certain specific needs that cannot be managed in the mainstream. CBC has really tried, the system has really tried to have them involved actively in certain activities that are able to stimulate them. But most importantly, I have to also say that teachers, especially teachers who do assessments and so forth, are very well trained in Kenya. I've had conversations with them and they do a fantastic job of an assessment. Now, the gap is in what we're talking about. One, it is extremely expensive. So you'll find that most institutions might not be able to do that. It needs, and again, I'm speaking about expenses, it needs capacity. You need capacity to be able to actually really ensure that you have an individualized educational program, for example, that really is able to help this child for a very, very long time. Private schools, I must say, they have tried, they do a good job. They have systems in place where they have teachers, they have small classes, they have tried to do their very best to accommodate children who are on the spectrum within the mainstream classes. Of course, sometimes it gets to a point where they have to do a reevaluation and make decisions. And I think, again, with a multidisciplinary team, which involves a pediatrician, a psychologist, an occupational therapist, and of course, the institution, to really evaluate where the child is at. And in these private institutions also, you find that they have not only the teachers, but they also have psychologists who really do a fantastic job. Honestly, I can't say at this point that we can compare. We hope that someday soon we can be able to actually move to the next level where we collaborate and find ways of how we can be assisted on this side. Because there are associations here, there are people who are very well learned, who are skilled, but now the how and the support is what is lacking. Particularly, you can imagine the rural setup. The urban setting is a little bit somewhere, but the rural setting, there's nothing. Nothing, kabisa. And I think you've seen, unfortunately, even memes that sadly, in this day and age, stigmatize children with such challenges. Thank you.
Nema, same question. What in terms of what are we doing? Like once you get the diagnosis, what next?
Okay. So yeah, so usually once you get the diagnosis, now of course it depends with the age of your child. So assuming this was a diagnosis that was done during toddlerhood, like you know, you are trying to see if my child can actually go to school and which type of school, and you know, what do you need to support the child. So ideally, you should get an educational assessment. Once you've gotten your diagnosis, the way you write the report, there are going to be recommendations based on what the person, the developmental specialist or the pediatrician thought they saw in your child. And then the next stage is going to be on educational assessment. So in Kenya, we have Kenya Institute of Special Needs Education, which, how do I say it? It's overwhelmed, you know, with the high number of diagnoses. It's really difficult for them to really catch up with the demand. Yeah. So that's why when I shared my story, I was told, okay, you can go to KISE and, you know, submit your papers, and then somebody will reach out to you. And that has never happened to date. So, you know, so what happens when time is moving, your child needs to join school. So that means you really need to look for other ways of doing this educational assessment. And that means you have to approach the private teachers or consultants who will be able to do for you that assessment. That assessment is not cheap. It's actually very expensive. But yeah, so that's the next stage. You do the assessment, then you get a report and a recommendation of the type of school that your child needs, whether they're going to fit into the mainstream, are they going to fit into the special needs, and then what should be the you know, teacher-student ratio. Do they need a shadow teacher? And then once you are able to get that school, because now there's the getting of the report and then there's the getting of the school that fits those needs. I mean, it's crazy. So assuming you get, because I remember I had, you know, like when you have a child, there's schools that you want your child to go to. I remember I went to all the schools, and all the schools were not able to take care of my child. So I was just left like, okay, so what's going to happen? It is so discouraging. It's really tough, by the way. It's really, really tough when you are told, okay, let's spend time with your child, and then you come in the evening, oh, unfortunately, we'll not be able to. Oh, unfortunately, we'll not, you know. So yeah, so the hustle and bustle of looking for a school, it's so tough. So as now, assuming you get it, and you need a shadow teacher, and this is also my personal experience. A shadow teacher means you have to pay an extra teacher to take care of your child. So basically, you're paying the school fees, and then you're paying a shadow teacher. And then, so they do that, and this is my personal experience. You do that after 2 terms, you realize, okay, something has changed, because now you are seeing regression. Because as Trish said, these kids need repetition. That has to be a continuous thing. So if anything changes, you are going to peak. Because if you're used to staying with your child, doing homework, you know, having conversations, you'll know something is up. Just to find out, actually, this school, the shadow teacher you're paying has been given some work in school. Yes, so that means, okay, I have to draw my child, and then I'll go back to the drawing board, look for another teacher. So you have, like, it's I don't know. So that's the situation. That's the situation. But once, if you get a school teacher, then the next step is getting an IEP, of which, like, now you sit with all those people, and I, for all parents who are parenting children on the spectrum, I always want to tell them is, you have to be empowered. You have to speak for your child, because most of the teachers, they will do the routine. You know, this is how things are done. This, you know, my child is this age. This is what is expected. But you have to really put your foot down to say, no, I don't think if my child is here, I would want him to be put here so that we are able to make progress. I believe in mastery, that before we move from A to B, I have to master A. Otherwise, there's no just a point of just going through, and say, okay, I finished this, then I move to this. Because if there's no mastery, usually with early education, everything is usually built on top of each other. So for parents, you have to, especially when you're doing your IEPs, you have to be with the teacher, go through all areas, your cognitive, social, the daily activities of living, speech, learning, like my child has issues with learning, all these body, how to take care of their bodies, all these areas. And you really have to speak for your child, unless if your child can attend that session and be able to speak for themselves. Yeah, so after that, then the child goes to school and just you pray that everything goes well. Yeah.
I know we've dwelt on the education piece a bit because we are Kenyans, but can someone touch on the nutritionist, occupational therapists, and physiotherapists? And this is across. Trish, let's start with the bougie side first, yeah, and then we can go home. Okay, let's start with the way in a system that works. The OT, PT, nutritionist, and any, speech. Yeah, speech is also different. Yeah.
Okay, so in most schools for students with disabilities, you do have related service providers. That's what they're called. So your OT, speech, physical therapist, occupational therapist, which is OT, sorry, counselors, all those fall under the related service providers. Within speech comes the feeding, because some students have, feeding issues, which affects, communication and stuff like that. So the speech teacher usually handles that. With the nutritionist, that one now becomes it's on the medical side of it. So we would probably recommend seeing the pediatrician to determine what foods are best suited for your child based on, their sensory needs or basic, allergies and stuff like that. So what happens is during the course of the school day, we incorporate the services within the school day. There's some who need more intense support. So what they do is the therapist pulls the child out of class. I don't recommend that too much, because when you pull out, the child is missing out on instruction that's continuing in the classroom. But if their behaviors are so severe that they impact the other students in the classroom, pull out may be the only option. However, like I mentioned, you try as much as possible to ensure that the child is within the least restrictive environment, less intense environment. So as you pull out, you're also doing a few sessions in pull-in so that the child can start acclimating with being within the classroom and acting accordingly when the therapist comes in. When it's pushing, the therapist comes in while instruction is going on, the therapist helps where they can. So if it's the speech teacher, if it's answering questions, you support the student with being able to answer questions when the teacher asks questions and being, a part of the class, participation and stuff like that. If it's the counselor, you come into the classroom, you support the students, because some topics are triggers for these kids. If you're talking about fish, just basic fish, it could affect a student negatively because they just have an aversion to fish. So the counselor, probably during those times, the counselor is there during that kind of a lesson so that they can, de-escalate if anything should happen. With behaviors, we do have a behavior team, and we have, like I mentioned, the student has a behavior plan. So when behaviors start to exhibit themselves, we try to de-escalate as much as possible. All teachers are trained with the program that we use at our school for behavior management, and you try to de-escalate as much as possible. If it starts to boil over, you try and remove the other students and put them in a safe place, call in the behavior team to try and help de-escalate. And once the child has de-escalated, you bring them back into the environment. Occupational therapy is key, more so in the elementary age group, because with the sensory issues, some of them just don't want to touch anything. So you're teaching them how to hold a pencil. Some don't even know how to hold a pencil because, their fingers are stiff and stuff like that. So it's a lot of repetitive stuff. And I would recommend, like in Kenya, where we say that the services are expensive, this is stuff that you can do at home. Maybe go for one session. If you're able to pay for one session, go for one session. see what the therapist is doing and take that home with you and just work on that, work on that, work on that. If you have access to the internet, if you go on Google, like we've mentioned, social media is great because there's a lot of parents out there who are showing you what they're doing with their child. They're showing you the stuff that they're doing with their children, which is working. And again, I must say that with the students on the spectrum, sometimes it's a trial and error thing. You may see, it's not a round peg that fits in a square hole. What works for Johnny doesn't work for Peter. And that's why it's a spectrum, because everybody exhibits the disability differently. So you have to see what works for your child, and then you take that and you run with it. So it gets difficult for those in the rural areas. But one thing Kenya is great at is that somebody in the village has a cell phone and they're able to access the internet. So if they go on there and they look into like YouTube videos, my child is stacking up things 24/7, putting cars in a row. That's a telltale sign when they're still little. They don't want to play with other kids. They're just in a corner and they're lining up cars or stacking up your cans of things that you're, in the pantry. That's kind of a telltale sign. So at that point, maybe I need to go to the health center and seek support. I know this is like huge because we haven't even gotten to the point where in the village we're telling them that there's this thing that's called autism or whatever. But if you have access to the internet, I would say use the beneficial part of it. Go and see what some speech therapists go on there and they actually put, the things that they're using to support their clients. You could take from that. There's this lady who blew up during COVID. I think her name was Miss Rachel. All the kids love Miss Rachel. You turn on YouTube and everybody's going to Miss Rachel. I think she's a speech therapist and she has a lot of things that she uses with the little ones to help with navigating the speech side of the disability. But within the school, everybody comes with their set of expertise, and then we just work together to make sure that it works. I'm not going to say it's easy. I have slackers. I have to run after people. Hey, did Johnny get his sessions? Oh, Peter was having a crisis. So Johnny missed his session because Peter was having a crisis. Now we have to do a makeup. So it's a lot. It's a lot. In an environment like Kenya where the supports are not there and it's already overwhelmed as it were, how do you manage because it's not a fluid situation. Trust and believe it's not a fluid situation. We go in every day with lesson plans and guess what? You have to modify because Peter came in and the parent forgot to give meds. So Peter is all over the place. Now you're moving the other kids to another location. Remember, they have autism, so change is hard. So once you've moved them, now you have to settle them in. And then now you have to now try to figure out where were we? Let's move on. And then remember, Peter also has to get caught up. So you have to figure out how you're going to get Peter back into. So it's a lot. It's not a straightforward thing. It's a busy day. You go in expecting anything. So you have to be ready. You have to be on your feet 24/7. We also have elopers. Kids who just take off. Beginning of the school year, we lost a student. That was hard on administration. Like it was hard. Kid just walked out the building. We didn't know where he was. We were running left, right, center. The cops were called. It was tough. And we have to understand that will happen. We are a school so we're co-located. And within our building, there's at least 6,000 students, right? So you have a student who doesn't have a one-to-one paraprofessional. Kids are crossing paths with each other because that's what they want. They want inclusivity. We could have a school on our own with those kids, but how beneficial is it to them? They have to be integrated with their peers. So you have a student who doesn't have a one-to-one and they wander off. Some of them actually take off. I'd rather they take off because you see them taking off and you chase. But the one who just gets caught in the mix and just ta-da, and you realize you're counting heads, 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. I'm missing number 6. Where's the 6th kid? So there we go, pandemonium, activate missing kid protocol, lock down the school. It's a lot. So every day we go in, you drink a Red Bull and you say, here we go. All hands on deck, gloves and everything, you go and you do what needs to be done. So I do appreciate that is not possible everywhere. I could see that being difficult to, implement in Kenya because we haven't gotten there yet. However, in terms of the related service providers, as you had mentioned, I would recommend that if a parent has access to the internet, just go on there. There's a lot of stuff. Even us as teachers, we go on the internet and we find resources and we come and we try it in the classroom. Okay, will this work? Maybe we have a sensory section for the kids who have sensory issues. And when they feel like they have had enough, they can just go and sit in the sensory section and come back. stuff at home that we have every day. You could have your child be the one who maybe cleans surfaces, because we're talking about post-secondary, right? Restaurants need bus people to wipe tables and stuff like that. Granted, it's not your most prestigious job, but it's something for them to do post-secondary. It's something for them to earn their little cash. You may have a gorgeous child who likes to take pictures. Look into modeling contracts. These days, everybody's trying to be diverse and inclusive. Look for modeling contracts. You have a child who can sing, because these kids have talents. They have strengths that people overlook. Just because they have a disability, oh, what am I gonna do? But your child can sing. Your child could probably draw. As silent as they are, they sit in the corner and they draw. Get them crayons. Let them write on your wall. Let them do a mural on the wall. You know what I'm saying? Whatever is there that is available and is an opportunity for your child, use it. Speech, things like speech. Talk a lot to your child. You know, when they come to ask you for something, they may just pull you to the thing. Require them to ask. Just say spoon, if it's a spoon that you need, rather than drag me to the spoon. Stand your ground and be like, what is it that you need? Use your words, you know, and that will encourage them to know that, okay, maybe I need to verbalize in order to, because some of them have select mutism. They just will not speak. So using the things that you have in the home, some of them with occupational therapy, okay, maybe a can opener, have them hold the can opener, grip it and do. So they're able to do stuff that's within the house that's affordable to you and helps them, because a lot of them also have hand-eye coordination issues. So maybe that person can be the one who arranges your cabinets. So they're able to see, this is the pattern that's being followed, so let me arrange this, the cabinet. Doing laundry, maybe have them fold the clothes. Your drawer that has spoons, knives, forks, and whatnot, disarrange it. Have them arrange it. And that's stuff that they like. They like order. They like order. So push that. Maybe they can get a job in a place that requires, say, for instance, a clothing store. Clothes need to be arranged in sizes. Customers are belligerent. They come and just throw things all over the place. They're giving our people a job, because now that is a job that they come and do every day. Just make sure that the racks are neat, make sure that things are sized correctly. And that's a strength that they have. You know, they don't tire to do it. We get tired, you know, like, I'm not doing that anymore, but they don't tire. So you look for little opportunities that are beneficial to your loved one, and you hone on it. You just push on it. But the internet is definitely a great source in terms of finding alternative ways to support your child in the absence of therapists.
Okay. Tumevuka sakafu unyo. Lambert and Emma, the Kenyan said, and also speak to, you know, this blanket condemnation of foods, because I know we've had this discussion before, and there are parents who are not giving the children, and this is the nutrition bit, the correct foods, because they've been told this causes autism and all that. And speaking about that, after this, I think we'll cover the myths. So what in terms of PT, OT, nutrition, speech therapists, what's on the table in Kenya?
Lambert?
You know, how I wish we had these experts in the house, because
I
the
said
reality is,
occupational therapists.
yes,
joining.
I think you can chime in, because really.
Veronica, are you able to speak up? Veronica, if kama ujenda kupika, if you can talk, or if there's any other occupational therapists undercover over here. Yeah, sorry. Okay. And if it's not your expertise, that's fine. We can.
Yeah, we don't have to represent them, because we work with them, maybe not in the same place, a lot of referral here and there. So it's unfair for me to speak on behalf of another professional. Yeah.
Granted. Okay, then let's talk about the myths. Myths that surround autism, and if you can start with the big one, vaccination. Let's go with the pediatrician here first.
Okay, yeah. So as you said, the vaccination is a huge myth, and yeah, it's a huge myth. I think the issue happened, it was related to the vaccine, MMR vaccine, that is, okay, in Kenya, we give MMR, okay, we don't even give MMR. So in Kenya, the way the schedule is, you get at 9 months, you get the measles, Okay, maybe for the sake of everybody. So MMR is measles, mumps, and rubella. It's 3 vaccines in one. So in Kenya, at 9 months, we get the measles only. And then at 15 months, the one that I was talking as a repeat, we get measles and rubella. So we have MR, we don't have MMR. If you're doing the Kenya extended program, we call them KEPI, the primary vaccines offered by the government. But if you are doing the private vaccines, then you can get MMR at 9 months and then still repeated at 15 months. So it really depends. And you see, for the private means you have to pay out of pocket, or if you're insured with a good cover, then the insurance may cover it for you. So yeah, so MMR has been a huge myth. And yes, there's been a lot that was written, but what really put a nail on that myth, in the coffin of that myth, was the paper that was published in Lancet, demystifying that actually that was wrong. The data was wrong. Whoever did the analysis was wrong. And because the argument was that kids who received MMR actually were more likely to develop autism, yeah. And so one of the biggest issue was the first symptom of autism happens at 6 months, yeah. And of all the kids who got the vaccines, according to that scientist, the doctor, some had the symptoms before the first jab of MMR, which is at 9 months. So if you are able to have the symptoms of autism, as you said, 6 months, where the eye contact was not there, the cooing was not there, the babbling was not there, this child was not interested. And then now you get the vaccine, and then the claim was after getting the vaccines, the symptoms now were becoming more evident. That means, so it was relating this vaccine to these symptoms of autism. So if these symptoms started at 6 months, then there's really, you cannot pinpoint that is the MMR that caused the advancement of this. It was just a matter of time. As autism is a neurodevelopmental. As the brain develops, those symptoms are going to be there, whether you got the MMR or you did not get the MMR. So that really canceled all the myths. But still we have, vaccine has a lot of issues. There's a lot of issues and beliefs and fake news and true news about vaccines that, it's because of all this, that's why we are having this. Because now people are really trying to understand, why do we have a lot of autism? Even currently, why do we have a lot of autism? And, one of the things people, Kitambo, we never, like if you're in Kenya, you see this idea of private vaccines are recent things. So they are kind of relating all these new things directly as a causal effect relationship to kids who are getting autism. So there's also that, but yeah, from science point of view, there's no relationship between your child getting these jabs and you developing autism. I'm a mother of 3. My eldest son is the one who's on the spectrum, and they all got the same things, but it's only one who really developed the autism. So yeah, there's no relationship. And recently they identified the gene of autism. There's actually a gene that is linked to autism. So yeah, so the vaccines is not one of it. Yeah.
Lambert, are there other myths that you know of?
I'll focus on our context, really happy context, because really for the longest, mental illness has been associated with witchcraft, curses, and that speaks to the reality of, for the longest, people hide their children. They don't bring them out because of the stigma they are in. So really, in our context, really, it's there are those myths that, if your child has, if you have a child who's on the spectrum, then there's a likelihood that your family is cursed, or there's something wrong with you and your lineage. Maybe you need to seek certain interventions and so forth and so on. But I think another important myth, which is very common even in a condition that is very close to my heart, which is ADHD, is that miraculously this condition will disappear at some point, which for sure, for the longest in ADHD, I used to think that after someone gets to teenagehood, then ADHD just miraculously disappeared. It's in the previous manual that was used to diagnose condition, mental health issues. So the same with autism, really, which again is on the same space of developmental conditions. So that's another myth. It does not disappear. Of course, just like we've been educated in today's webinar, the sooner you start, the better. Because with that, there's a chance of the child getting better in terms of communicating and really interacting, developing social skills and so forth and so on, which is the same with ADHD, depending on the severity. So those are the two myths that came to my mind.
Trish, is there a myth on the teacher's end that you know of, or that's Lambert and Emma's?
I would revert to Lambert and Emma. Although
Okay.
we do hear parents saying, "Oh, it was the vaccines. Once he got the shots, this started to happen and stuff like that." So we don't delve into we're prohibited from making any medical diagnosis or medical suggestions into what the cause was. We're just here now to support you and help you for their 18 years of life, so that when they age out of our programs and go into post-secondary placements, they're able to manage as best as they can and acclimate into society as appropriately as possible. And if not, give you avenues to which you can now, seek support for your loved one. But in terms of the myths and stuff, we hear them, but we just do the best we can with what we have.
So I'm gonna ask the myth. Phyllis Muragori is asking about is autism caused by a traumatic experience, like a kid may have fallen and was hit on the head? It's very prevalent in my East African siblings here. Not my Somali siblings here always, because of the stigma that surrounds the condition, they keep saying that the child fell during the war, even when the child was born here. So it's a myth that's prevalent. Is it true that trauma and both physical and emotional trauma, does that lead to autism? Medics.
No.
Okay, good question.
Oh, sorry.
Go on. Ladies first, go on.
Okay, no, I mean, when you look at the neuroscience behind autism, no. However, there've been, it's not a causal effect relationship. It was more an association relationship of traumatic brain injury in the womb and autism. It's not a causal effect, it's an association. That means, yes, that was there, but there are other factors associated. It's not like, you see, like something like cerebral palsy. When you have a brain injury, your child may end up being born with cerebral palsy. So that's a causal effect. But then association is, there's that, and then there are other factors, and you are not sure which one has more weight than the other. So there's been association with a brain injury in the womb with autism, but this one of a traumatic experience when the child has been born already, no. I mean, autism is a neurodevelopmental. That means the brain of this child is developing differently. Yeah, that's what autism is.
Lambert?
A good point. I don't want to add anything else, though what I can just say, the environmental factor, because you see, if you're in an environment where is neglect, an environment where there's physical abuse, verbal abuse, sexual abuse, then of course a child who's autistic cannot really stand up for themselves, might not be able to communicate, and maybe then you will see the reaction in their behavior. So maybe it's just that it can, some of this, then trauma can exacerbate some of this, the problem that you're already seeing in a child who is on the spectrum.
And also affect early intervention. Because
Exactly.
if it's gonna delay it, the child won't fare very well. Okay, the questions in my head are done, but I just want to ask, yeah, they usually, because my tribe, we have to eat. Both in the Ukuma, US na back home, we have to eat. But I'm just wondering, is there anything that I didn't touch that the panelists would want to touch on? Okay, let's start with the ladies. So let's start with the teacher, Trish.
No, I don't think so. It's a very broad topic, very, very broad topic. It touches on literally everything that you can think of: medical, social, education, home life. So there's a lot. I don't think you can discuss autism in one sitting, but in terms of the basics and the essential piece of it, I think, you know, you did a good job of moderating. My fellow panelists were really good when they talked about the medical side of it, and also bringing, you know, to the forefront that it is different in Kenya than it is over here. I think you know, you did an exemplary job.
Nema?
I think okay, maybe I have a question to Trish. And this is on inclusivity when it comes to how you integrate these kids in the classroom, in the bigger classroom. Okay, I just want to know, what criteria do you use? Which children are to be included and which children are to be in the special needs unit?
So we have a rubric that we use. And for the most part, our rubric weighs heavily more on the social aspect of it, because we find that kids learn from kids. So if they're able to interact with their peers, they copy behaviors, and then they start to do, you know, what their peers are doing. So there's that factor. Then we have students who are extremely capable of acclimating, but the behavior and the general autism is a hindrance. So for a student like that, you send them over with the support of a one-to-one paraprofessional. If a child definitely has like serious temper tantrums, you know, and it's every 5 minutes it's happening, that would not be, you know, a very good candidate for inclusion, only because we have to also consider the other students on the other side and how it's interfering with the general progression of the classroom. But it's kind of like an innate thing where when you're teaching and you're walking through the classroom, you can see the kid who okay, that one, we can move them over. But before we do so, we do a visit. We take them, like, let's say every Friday, they visit, they hang out, they have a full day with the general education population, and then we do it. But another thing is it's a change of program, because they're going from alternate assessment. So here, alternate assessment means that they don't take state exams, they don't take national exams, and they don't graduate high school with a diploma. They just get a certificate that says they were in the system for 21 years. Whereas standardized, they're taking the exams, they'll get a high school diploma, they can proceed into college. So when you're moving them from alternate assessment into standardized, it's called a change in program. So at that point, say for instance, me, the teacher, I've noticed, and I'm like, okay, Peter seems to have it going on. Maybe we could try and move him into least restrictive. I reach out to the psychologists and I'm like, I have a student who has potential. So now they sit down and they do the whole picture. They'll do the psychoeducational, they'll do the psychological, they'll check the IQ. And I have to mention also, we have a serious problem with the parents sometimes, because in the US, if your IQ is at a certain point, you get a check from the government every month. So a lot of parents do not want, they'll tell their child, you go and you fail that thing. don't, or the parent will refuse us to do evaluations because the minute the child passes that threshold, now you stop getting that check. So there's a lot of factors that, our hands are tied behind our backs. And that's the instance where now you have to, call in educational negligence, and the state comes into support. But there's that fear as well, because if they cross that threshold, now they're not getting the money and the supports that they need. And as mentioned, these things are expensive. Getting those supports are expensive. Getting that, outside ABA, getting that outside home sets, the support is expensive. And once I pull that rug from under you, now you're on your own. You know what I'm saying? So there's a lot to consider there. But in every situation, you try and do what's best for the child, not what's best for the school, not what's best for the parent. It's what's best for the child. So you look at it as a whole sum. Mom can scream and carry on, throw a tantrum, but if you see that this child will manage, this child has the capability of going to college and making something of themselves, we kind of tend to ignore the parent when the parent is pushing in the wrong direction. We will even welcome the lawsuit and we will go and fight for the child's benefit. But it's a whole process. You sit down, you look, and you sit down as a team, and the therapist will say, yeah, I think that it's a good idea to move him over. Admin will also look at the data, and then data is huge. Data is huge. So over time, you're collecting data. On that IEP, you have weekly check-ins where you're checking in whether the child is meeting the milestones, or whether they're meeting the goals, and it's continuous. So all that comes into play when you're suggesting that this child should move into the general education population.
I know we didn't cover caregiving. Caregiving is a whole topic, but for the people who need to watch, we did a caregiver fatigue session. I've shared it. Please watch it. It was wonderful. But there are autism support groups. I know Nema, you do one, but also my friend Cindy Mushine also has one, Autism Kenya. She has an older child living with autism, and she's done the whole shebang, and she's like me, she's very straightforward and to the point. So follow her. Nema, you can put your page here. I think you also do a good job. Lambert, Natrish, no, I've seen your socials. Trish is not for autism. Okay, Lambert, sorry. I'm sorry.
I'm here for selfies.
Yeah. Lambert, do you have anything I didn't cover? And if you can cover this child who wasn't listening to the child is Saya, is asking if there's late, which we covered at the very beginning. Is there late onset autism in adults, and what exactly happens in the analysis? We can give it 3 minutes.
I think, like Neema's put it, and we've all put it, it's a neurodevelopmental condition. So you're born, it starts in childhood, so it's there. So it's just that maybe because of the challenges within the environment, also the presentation of the child, where the symptoms are not overtly clear, then there's delayed diagnosis. So you find that the person is diagnosed much, much later. Though with a later onset, and it's nothing that I know of. And then, which was the next question? Clearly, my head is tired. That's how we do the
analysis.
The
analysis.
Analysis. How we? Really, I think the simple gold standard of actually analyzing for any condition, especially the autism spectrum, what we're talking about is observation, really. Just observing behavior of a child when they present to you, and getting lateral history or history from the parent or the guardian or the caregiver, from schools, also getting information from if this child is going to school, getting as much information, sending questionnaires to really understand more about this child's environment and the teachers, their input. And I think also, most importantly, one of the ways you can engage the child is play. through play, you can engage with this child, you get to their level, and you're able to assess their level of eye contact. You're able to, like we had said earlier, play with toys and not try and check whether there is that obsession or the need for maybe speech, echolalia, I think was mentioned, repetitive behavior. So it's a whole process where you spend quite a bit of time with a child. But what sometimes makes it easier is by the time a child comes to us clinicians, they already have an idea there's a problem, and they already have a lot of information, which makes it very easy for us to do an assessment and give our recommendation.
Could someone just answer Nancy's question on how to control the meltdowns? I try to just say it's a behavioral therapy thing and it has to be continuous. This is me putting on a very fake autism specialist hat, but is that true? Was I right? How to deal with the meltdowns?
So the questions addressed me? Oh, no, not me. I think
it's been asked. Yeah, Nancy. Yeah. Nema,
yes,
that's you and Lambert.
So by the time a child goes to meltdown, it means they are overwhelmed. Like, that's not where they start. That's where they end. Like, so as a parent or a caregiver of a child on the spectrum, you need to be empowered to know your child, to know the telltale signs of, okay, when I see this, it means my child is actually being worked up, okay? And this, usually the first stage before a meltdown is usually steaming, yeah? Yes, usually kids steam to self-regulate. So if for any reason you start noticing the steaming is actually getting worse with time, just, okay, Veronica, you can share after me. Just know that there's something in that environment, or there's something that they've seen, or there's something that they're experiencing that is slowly pushing them to the edge. And when they get to the edge, a meltdown happens. So there's usually no one strategy to say, so when you see a meltdown, this is what you do. But the question is, what is the trigger of the meltdown? Because if you do not know how your child is processing the senses around them, you may try to hug them, they may push you away. You may try to calm them down by maybe, let them lie down, but that's not what they want. It really depends with how they process the information. So, and that's usually the beauty and the challenge that comes with autism, because it's a spectrum disorder. Veronica, you can add on that.
Okay, my name is Veronica. Forgive me about my voice, but I'm going to share about the meltdown. So we, as an occupational therapy, for now I'm working in Tanzania, but I am a Kenyan. So I advise parents to know the before, during, and after. So before means what happened before the meltdown. So for a parent, you need to know the triggers. Maybe it could be noise, maybe it could be a large group of people. So as a parent, you need to know what happened before the meltdown. Then during the meltdown, what do you need to do? For example, when you are in a large group of people, you need to take a child in a separate room, allow him to experience that meltdown and to make sure that he's safe, and what happens after the meltdown. So as a parent, you need to know all these triggers for a meltdown. So there is not this specific meltdown that happens, but you as a parent, you need to know what triggers, what you need to do during the meltdown, and what happens after the meltdown. Thank you.
Nancy, I hope that was helpful. Okay, I think I am done. Saya tufunge kituo, and we do not have an after Nyuma attend part. I need to drop employee.
Can I add on the part with the behavioral challenges?
Okay.
So as mentioned, you have to know your child's baseline. So that means you know what normal looks like in his or her world. And as Naima mentioned, stemming could be a sign that I am not comfortable in this environment. something needs to change. Some of them literally put their fingers in their ear because sensory, it's too loud. I need to get out of this space. And you as the parent or the caregiver or the teacher should be able to notice those on the drop of a hat, because failure to do so, it'll start to increase. And once it starts to build up, you have to let it go its course. You're not going to stop it. It has to run its course. You're just not going to stop it. Now, when it reaches that point, you have to make sure that you get them into a safe location, because self-harm is going to happen if they are not in a safe location. The person is seeing red. And a lot of times when they have behavior, people think we're trying to come by, and no, they're communicating with you. We get hit a lot and we don't take it personally because we're like, this child is trying to tell me something. There's something they're trying to communicate and words have failed them. Communication is not working. They're trying to say something. So you need to sit down and get the cue and be like, what is it in the environment? And it's usually environmental. Something in the environment is not sitting well. Also understand, their other senses are heightened. So what you're not seeing, they're seeing. They're probably letting you know danger is around. Just like, for lack of a better term, an animal. They could be very calm and then all of a sudden they start barking and you don't know what's going on, but danger is lurking. So their senses are heightened. Their senses are so heightened that maybe it's danger towards all of you, or they're just not comfortable in the environment that they're in. So you really need to cue in, take time to understand what's going on, but also understand that when they start to, when the meltdown is happening, strapping them down and tying them down is not the solution. You need to get them to a safe place and let it just ride its course. Because when you start to hold down and pull their hands back and, like treat them like criminals, you're not giving a positive reinforcer. Instead, now you're letting them know you're not the person I can trust when this starts to happen. So you need to get a safe place. Some people put a room where there's nothing, it's just an empty room, and you let them just go in there and let it run its course. We don't encourage that in the schools because it's almost like you're putting them in a padded room. So we don't encourage it. So there's this thing that we are all trained on, it's called therapeutic crisis intervention. And we really, really, really focus on the antecedent. We focus on what is it that is, causing this, because it's usually something that's established. The antecedent is always something that's established. It could be they hate, like we have a student that every time there's an announcement for a fire drill or an emergency evacuation drill, he's gonna have a meltdown. He's gonna have a full-blown meltdown. So we also know that he likes to be in charge. He likes to help. So what we did, we gave him a fake walkie-talkie. It doesn't work, but it looks like all of ours. And we gave him the emergency coat, the orange one. So as soon as he hears that, he goes, he gets his coat, he wears it, and he starts paging. I don't know who he's paging, but he's paging somebody. Now that's the difference between him having a full-blown meltdown, beating everybody, and we're unable to bring him to safety, than for him to think, oh yeah, so you distract the thought process. You bring him to think about something else. Oh, I am responsible here, I need to bring people to safety. Granted, he's not doing it, but in his head, this is what's going on. In his world, this is what's going on. I am responsible for getting people to safety. The alternative is we don't give him the orange jacket, we don't give him the fake walkie-talkie, and we deal with him kicking and screaming and just full-blown meltdown in the middle of an emergency. So you have to understand your person, understand what the triggers are, and try to mitigate, not, try to ensure that the environment is in a place where it doesn't trigger the person. And if that happens, then try and do what you need to do to get them to a safe place as soon as possible. But don't beat it out of them. Don't, handcuff them. Don't, harass them, because the next time this happens, they'll know to go away from you to have their meltdown because they don't trust you. And that's one thing about them, they know. People think that they don't know, they know. They're probably smarter than you and I, because like I mentioned, their other senses are on high alert. So that's all I wanted to add.
Dr. Patricia. Okay.
Please allow me.
Okay.
Dr. Patricia has provoked me. And allow me a humble request.
Okay.
A humble request. Kindly, if you could organize a similar event where you deliberately invite parents who not only have children and adults on the spectrum, but neurocognitive developmental issues to actually engage with Patricia, because I think Patricia is very, very resourceful. And I believe we don't have to go to YouTube. Unajua sasa sisi, some of us Kenyans say, no, this we are all school on YouTube. No, we want to listen to Dr. Patricia.
Okay.
We want to listen to the person herself. So kindly, if maybe, and I believe we are moving past just giving information, educational stuff, but really kind of giving skills. Because I've just listened to Patricia and I'm amazed by the skills that she has acquired over the years, managing such a big school, managing such a big team. And I believe then, even with time, we can borrow a lot from her and she can help us put up some of those systems in our beloved country. That's my humble report.
Help me get these people, because this, I
Not
don't know
a problem.
what to do.
We shall do so. We will,
Because
actually
Patricia is
mobilize.
draggable.
Yes,
she
honestly.
comes with me, yeah.
Yeah,
Yeah,
just texts me and says, I need you. I'm like, okay,
yeah.
Oh,
Patricia is
wonderful.
draggable.
Thank you.
I'm
Thank
easy.
you. No, I will do that.
Yeah.
We'll do that. I will talk to all the people I know. I will do the campaigns. I'm sure I'll get other psychologists to do the same, and we can mobilize guys. And then we set a date, and then people will come.
And if you give me prior knowledge, I can also loop in our therapists, speech therapists, occupational therapists, some of our counselors, because they come with a wealth of information, you know. So I could definitely do that as well.
Fantastic.
That's your homework. Yeah. Me get me the people. Trish.
Not a problem.
Yeah.
Tutanza, we'll start. We'll continue this conversation. Yeah, we'll pick it up. And of course, Neema. I'm sure you also know. Yes. Yeah.
So she's taking it from both sides. So she knows what it is to live with an individual with a disability. And she also knows the other side of it. Like she mentioned, you could see it, but you cannot be the one that treats it because you're clouded. You're clouded. So it has to be somebody else coming in to support you. So
thank you.
And you know my turnaround time is Lambert.
I know.
Okay, Saya, funga kituo. Go ahead, Lambert.
I said, I'm on it.
Okay, Neema, bring us people. We are here to educate the masses.
No worries. I only need a date and venue.
Okay, well, let's just put it here and now. After November, no Kenyan listens to anything. Ni sherehe, and then they are broke in January. So like all our, we end our Zoom things in November because we've discovered December we'll just be talking to ourselves. Then we will come back in February. So from but for this special session, if there are people, and Trish is in this country still, because even all of us are sherehing, if you give us a date and time, yeah, but just remember, Kenyans piga sherehe in December, January they're broke, they can't even afford bundles. Then February they come back. It's reality. Yeah, you agree, right?
Yes, absolutely, I agree. We should start organizing ourselves and plan for next year. Okay. We can identify a date and then now we start tying the loose ends and come up with something.
Okay.
So that we can have as many numbers as possible. Yeah.
Namjue clock yetu imeruka, so itakuwa 6 p.m. and atuamki for your sake, 6 p.m. until when does the clock ruka again? That day. Yeah, but inaruka next week. This is why I need an editor for these videos. Like, what is this gonna be doing on YouTube? Okay, Saya, go ahead.
Yeah. And that last portion is a good testament of why we began doing these authentic dialogues. It's a good vision of organic movements towards solution that we would like to see. So it's a great ending. We wouldn't script it any other way. So thank you so much. I I have learned a lot. I have really learned a lot. One thing I have learned is in Kenya, tunaishi kwa neema, we just live by grace. Yeah, like the systems that are here in the US, they are, it's good. It's good for people to learn across the board. Just 1 second. I have a visual disability. I have lived, studied, everything, married in Kenya with it through struggle. And then when I came to the States, the sheer amount of resources and support that is available is like there's a library not too far from my house dedicated to resources for people like me, a full-fledged library that ships to me audio books. Yet for my entire 844 time, I studied normal books like every other student, had to figure out how to read blackboards and stuff. So yeah, there's a lot to learn, but awesome to be here. Thank you, Lambo, for being here. Thank you, Nema, for being gracious to be here. See what I did there. And thank you, Trish, for bringing in your bag of tricks. Yeah, so Lambo, you should look for something to go for lambasting us with your knowledge. And thank you, Posa, for posing the questions. We appreciate. Yeah, one clue of being a poet is you need to be good at daddy jokes. So maybe I'm halfway there. I hope we will become better, and we can share these videos with individuals who do need them, and I'm sure there are many who could benefit from this. Where will you get this material, and how else can you engage with us? Our platforms remain the same. Specifically for Authentic Dialogues, we have a YouTube channel dedicated to that. It's called Authentic Dialogues. Go on your way YouTube, you'll be able to get this video and previous videos. And then for every other day engagement, you can engage with us on Instagram, you can engage with us on Facebook, and the handle on Instagram is @SireJackson, and on Facebook is Authentic Dialogues with Sire Jackson. Yeah, so please like, share, subscribe. Please feel free to recommend questions, topics, speakers you'd like to address, and you could even volunteer yourself to speak. Of course, there'll be a behind the scenes chat to see suitability, but we really are open and cool beans like that. Paul has explained our rationale. November is normally our last month of operations because December is very volatile, and then January, part of our audience is broke and distracted and thinking of school and New Year's resolution. So we normally begin from February through to November, which means we take an 8-week break. So we're having our last 2 Authentic Dialogues in November. So this is our last one for October. In November, we're having one session on the 5th, and the other one is yet to be determined, but the 2 topics are determined. In November, the 2 topics we will close with is one, we will revisit the topic of endometriosis, going a bit deeper, and at least because I know we are going to have somebody who is living through endo, so it's something you want to be there. And then finally, we'll talk about our careers and mistakes we make in our careers, a fitting time as people are thinking about New Year's resolutions and planning and looking back, how will they think about their careers. So those will be the 2 topics for the month of November. One is on endo, then the other Authentic Dialogue would be around career mistakes. So through the same channels you've gotten to know about this, you will likely know about this. So be on the lookout. Once again, thank you for your time. You're the reason we do this, and we wish that you will be able to have the grace and the courage to have more Authentic Dialogues. Today, we are not having a behind the tent session, so I think after this, we will call it a day. Be blessed, and thank you for being here.